Hi, I'm Helena Mentis, and on behalf of my co-authors, I will be presenting Remotely Shaping the View in Surgical Telementoring. There is a significant challenge in providing the appropriate method for conveying expert knowledge in distributed work settings. Most existing research focuses on either the ability of local workers in showing their actions or the tools available for a remote helper to provide instructions. But a few studies have uncovered the nuanced behaviors that people engage in distributed work, such as showing gestures and actions in training and making local work visible to a remote expert. More recently, Mentis et al. 2016 went further by also demonstrating that a local worker crafts a view for the remote worker through actions and talk in order to facilitate the co-construction of knowledge and shared decision-making. Crafting is a deliberate execution on what to capture and how to capture it, thus invoking a particular view to be shared. However, in that study, the local worker recorded a small sample of video to send to the remote worker for discussion, and it was noted that the crafting of the view is only conducted by the local worker. In the following study, we observed surgical telemedicine events with streaming video and audio. The intention behind this investigation is to determine how the negotiation of the shaping process was accomplished by the distributed workers, as well as better understand the tools the workers had at their disposal to shape the view. The form of surgery investigated in this study is laparoscopic surgery, where surgeons use the laparoscope to see the operative field, and a cable then connects to a monitor, providing high-resolution images to the surgeons. Telementoring has been championed as a mechanism of improving specialized laparoscopic training and thus increasing its access for patients. That is when an expert laparoscopic surgeon remotely observes and instructs the surgery in real time in order to advise another surgeon on new techniques. The telemedicine system used in our study was Storz's Visitor 1. It is a secure, encrypted real-time audio and video communication system consisting of a medical-grade mobile unit on the local surgeon side, which is the picture on the left here, and the control station software that can run on a laptop or iPad on the remote surgeon side, and that is the picture on the right. Thus, the remote surgeon has two views, a laparoscopic view captured by the local surgeon using the laparoscope, and an external view captured by the remote surgeons using the onboard camera. I have a quick video to show the system in action. In the center, you see our remote surgeon on the Visitor 1, and our local surgeon is on the right. Be forewarned that the video towards the end shows a close-up of the laparoscopic view. At the end there, you will see that the remote surgeon also has the capability to point or telestrate on their display for the local surgeon to see.
Peritoneum to fish that loop exactly at the spot you want to.
So draw me a picture on the screen where you think the internal ring is.
Yeah, great out here. So Mike, this is what I would call the internal ring right here.
Okay, so
now, sometimes it might be.
The primary data collection was video of surgical telementoring cases in the U.S., such as you just saw. We observed 5 telementoring cases of 4 different laparoscopic procedures, approximately 15 hours of video, collected between 2016 and 2018, and the telementoring system was used the entire time. The analytic orientation we adopted was on the moments of talk and actions used by the remote experts to shape the view, defined as the effort spent by remote surgeons in changing the images or focusing the attention of the local surgeon on an aspect of the image. We began by conducting an ethnomethodologically informed conversation analysis, and then proceeded with an iterative open coding method. This analysis focused on how the remote surgeon shaped the view during the surgery. Specifically, did the remote surgeon have an opportunity to shape the view? And if so, how was this accomplished? And when was this practice conducted? Much of the shaping of the view was done by the local surgeons in service of his own task needs, as well as collaboration with his co-located assisting surgeon. Thus, it was very prevalent for remote shaping of the view to be a result of the local surgeon requesting guidance or confirmation on their work, such as in the following. The local surgeon pauses the grasper movement, as you can see in the view on 1A, and says, "So," the remote surgeon's name, "how would you start to approach this stuff?" And the remote surgeon says, "All right," the local surgeon's name, "show me more of the front of the fissure." The local surgeon moves the scope downwards, and then the remote surgeon says, "All right," and at that moment the local surgeon, still moving the scope downward, pauses, and that is the view in 1B. And then the remote surgeon says, so look up just a little bit for now. And the local surgeon then moves the scope slightly upwards and pauses, and that is the view in 1C. In this case, the request of the local surgeon opened the door for the remote surgeon to shape the view. The remote surgeon's response indicated that what was presented was not the view he needed, and to change it in order to set up the plan for the operation. Thus, his shaping practice consisted of requesting a different image by moving the camera. In the shaping of the view for this segment, though, the only tool the remote surgeon had available was that of talk. Directing the scope to capture a specific view required great effort. He had to not only precisely provide the orientation and name of the anatomical structure, but also verbally adjust the camera to capture a specific portion of the anatomy. Alternatively, in the following segment, the local surgeon is asking for confirmation as opposed to direction. Here, the local surgeon is determining the location of one of the insertion ports and asks the remote surgeon for verification with his decision. The local surgeon points on the surgical area, which is the view in 2A, and says, "You're okay with this?" The remote surgeon's name. The remote surgeon says, what I would do is I would look inside. And then the local surgeon at that moment orients the scope to capture the position of the insertion point inside the abdomen. And you can see this movement in 2B. This example is different from asking for guidance or an explanation, and thus is not an explicit call or even an implicit call for the remote surgeon to begin shaping the view. But because of the nature of the current view, the request for checking of work, and the unsuitable current view that would support that work, the remote surgeon takes the opportunity to request a different view for both surgeons to review and discuss. Again, the only tools the remote surgeon used are verbal utterances. The following segment is a continuation of the prior segment. Here, the local surgeon directly requests the remote surgeon to shape the view with a different method at the remote surgeon's disposal, a pointing and drawing tool. The local surgeon says, "Can you draw on it?" And the remote surgeon says, "All right," and he draws a circle on the video of the abdomen. The local surgeon then palpates above the circle, which is the view in 3C, and adjusts the scope. The remote surgeon says, "Do you know where my circle is?" And the local surgeon says, "I know, I'm trying, but see, look, I'm right at the diaphragm." There is an explicit invitation to shape the view here, to draw on it. In other words, use the pointing and drawing tool. By using the tool, he is shaping the view via a focusing effect on the images. This space that the remote surgeon has delineated is now the focus of the eyes as well as the discussion. This shaping leads to the articulation of a problem by the local surgeon, that he is right at the diaphragm, and that makes it difficult to insert the port at that location in the abdomen. These three examples so far represent the most prevalent events that led to a shaping of the view by the remote surgeon when the local surgeon invited the remote surgeon to share, reflect, or explain. But that strategy wasn't entirely sufficient for integrating the knowledge of the remote surgeon into the local surgical practice. We did have examples that were not a result of being invited to share the view, and instead the remote surgeon interrupted the flow of the operation to shape the view. This was usually due to a need to warn of a potential problem the remote surgeon saw unfolding. Here the remote surgeon says, "So," local surgeon's name, "pull your hook back for 1 second. So I think, right, lift up the cyst like what you're doing," which is the view in 4A. The local surgeon then lifts the cyst up, says "okay," which is the view in 4B. The remote surgeon says, "So right down there," and he draws a zigzag at the bottom of the cyst, which is the view in 4C. "I think it's where the superior artery is going to be in there somewhere." So what we see is the remote surgeon first restored the scene through interruption and talk, upon which he then shaped the view of potential risks on the superior artery through the pointing and drawing tool. It is noteworthy that the remote surgeon used "like what you are doing," a generalized reference to what the local surgeon was doing to describe the position that he wanted the cyst to be. Thus, the remote surgeon was able to set general directions on how to shape the view. The need to interrupt was often due to a concern that could not be determined through the video itself. This is related to the need to integrate the knowledge from interacting with the tissues in conjunction with viewing the images, as prior work has shown. As this interaction with the tissue was not something that the remote surgeon could accomplish, the interruption to shape the view was to elicit the work from the local surgeon. In this example, the remote surgeon says, Is there at 2 o'clock, is there a weakness of a hole in the peritoneum? And the local surgeon stops the needle insertion, and the local resident starts moving the Maryland grasper to the position referred by the remote surgeon. This? And palpates the target using the Maryland. I don't think. And the remote surgeon says, No, it doesn't matter. And the local resident says, Yep. And he continues to scrub the target. I think this is still the peritoneum. And he zooms out the scope. She had a little like a fold there, In this and the prior example, there is a need to stop the work being performed in order to further explore the view. The remote surgeon then directs the local surgeon as to what needs to be determined. Having the ability to stop the surgery and intervene is clearly still an important step in this distributed work setting. In all of the above examples, the image itself changed by switching from one camera view to another, moving the laparoscopic camera to another part of the anatomy, or zooming out on the image to see a larger area of the anatomy. However, as the cost to interrupt was high and the invitations to shape the view were few, the remote surgeons regularly just made do with the images they were being provided. Instead, the remote surgeon would use talking and pointing and drawing to shape the view to his communicative purposes. For instance, in the following, the remote surgeon drew on the laparoscopic video in the lower corner in order to indicate anatomy that was not actually visible in the image itself. The remote surgeon, looking at the image in 6A, what I would do is I would come right down here, and the remote surgeon then draws on the lower right-hand corner, and this is the view that you see in 6B, to the crotch of the major and minor fissures and kind of unroof that. Let's find the artery and then work to move those nodes out of your way. And the local surgeon says, got it, and he starts working again, which you can see right at the point where the image was drawn on in 6C. This is particularly interesting as the remote surgeon is trying to make do with the view they have to shape it further through talk as well as using the pointing drawing tool at his disposal to try to shape the view even further with drawing, which has the effect of focusing everybody's gaze. Our findings specifically build on the prior work of Mentis et al. 2016, where the manipulation of the images was prescribed by the sender in terms of what was captured. Our findings thus reaffirm Mentis et al.'s theory of crafting an image, in that much of the image crafting practices are conducted by a local worker, and the remote helper is simply meant to receive the images as they are provided. However, we are also expanding Mentis et al.'s theory in that, if provided a mechanism to do so, a remote surgeon will assert their own image needs on the local worker, and often this crafting is to serve co-construction of the view. And we are also challenging Mentis et al.'s theory that these practices are simply due to the nature of the work, in other words, primary worker with a helper focused on the worker's needs. In fact, we assert that if the system provided more mechanism to craft a view for the remote surgeon, we may see even more crafting practices towards both the remote surgeon's own image understanding needs as well as the co-construction process. Our reason for this hypothesis is due to a more recent paper by Mentis in 2017 that investigated the distributed work on images by co-located surgeons. One surgeon will move their attention away from the surgery at hand to craft an image on a secondary display and then bring that image back into the fold to share with the other surgeons at a suitable time for discussion and use. We think we could better support this remote surgeon's separation to craft need. The predominant telecommunication system designed for telemedicine is an asymmetric image interaction paradigm where certain image interaction functionalities are only available to one party or the other. However, we could provide equivalent manipulation and annotation ability for both distributed parties to use during discussion and decision making. For instance, the local surgeon having the ability to point and draw on the images themselves with perhaps a gesture-based telestration system. Even more impactful may be to address the lack of shaping ability by the remote surgeon, who could have the ability to manipulate the view or image being shown. This could be achieved in a number of ways, but I'll refer to one that we're exploring. We're right now developing and getting ready to test a prototype similar to this. In it, the remote surgeon can capture images or video snippets from a primary laparoscopic camera view and then work with them separately from the shared view of the local surgeon. It also allows for manipulation of the view, such as rotation, zoom, and annotation, that is propagated back to the local surgeon. So perhaps next year you will be watching that demo or study presentation. Thanks for listening, and please send any questions or suggestions to me via email or Twitter, and you can check out related work on my website.